This is our neurorehab diagnosis assignment over Guillain-Barre syndrome. What is Guillain-Barre syndrome? Guillain-Barre syndrome, or GBS, is an autoimmune disorder that attacks the neurons of the peripheral nervous system. This can affect any of the nerves that are outside of the brain and spinal cord, or the central nervous system nerves. The cause of GBS is currently unknown, although past instances indicate that the onset may be triggered by infectious diseases, as suggested by the increase in GBS diagnoses during the Zika virus outbreaks in the 2010s. The onset of GBS is often very rapid and includes a loss of muscle strength and sensation beginning in the legs and moving superiorly towards the upper extremities and upper body. To diagnose GBS, healthcare professionals must first rule out any other potential causes for the weakness and loss of sensation. If there are no other apparent causes, a lumbar tap can be performed to measure for abnormal protein levels in the cerebral spinal fluid consistent with GBS and conduct nerve conduction tests to determine the presence of irregular nerve conduction. People with GBS can also experience psychological distress and fatigue secondary to their symptoms. The prognosis of those with GBS tends to be positive, with 80% of those diagnosed showing the ability to walk independently again. The mortality rate for those with GBS is generally less than 10%, and mortality factors can include special circumstances such as increased age and severity of the disease when diagnosed. Long-term effects of GBS can include muscle weakness, neuropathic pain, and fatigue. However, recurrence of the disorder tends to be rare.
Range of motion and manual muscle testing would be one of the first things we assess to give us a picture of how much strength and joint flexibility the individual has lost and how much there is to work with when coming up with a treatment plan. Since there is also sensory loss with GBS, we'd want to test for light touch and sharp dull pain. The 6-minute walk test would be a good assessment to measure endurance and functional mobility. Lastly, we would use the Barre index, which measures the individual's level of independence in ADLs. It focuses on mobility, transfers, toileting, feeding, and bathing.
One intervention that we can do with someone who has Guillain-Barre is addressing relay game. For this intervention, we will use color-coded clothing and mirror work to encourage upper limb use and visual feedback to address bilateral weakness and fatigue. First, we will have them sit in front of a full-length mirror, then provide different colored clothing laid out on the table next to them. We will then allow them to dress themselves and provide cues, help, and encouragement when needed for upper limb and mirror use. Timing how long this takes them can also be implemented to make this more game-like and track their progress. Another intervention we can do with someone who has Guillain-Barre is walk and talk therapy, where the patient will complete light mobility in the clinic or hallway while discussing progress, solving problems, or sharing stories to address fatigue management and psychological stressors. First, we will make sure there is a clear path for them to walk and provide any walking assistance if needed, like a walker, wheelchair, or our personal assistants. Then we will talk or discuss whatever is of concern to the patient. Finally, we will make sure to have good communication between us and the patient so it can be communicated when the patient is fatigued.
A third intervention, we termed as Smart Hands, teaches joint protection through hands-on functional kitchen activities. To carry out this intervention, we need a simulated kitchen or common kitchen tools. To begin, we'd have the client demonstrate how they typically use this kitchen tool. Then we would educate through action. This is the part of the intervention where we would provide the education. For example, sliding versus lifting, assistive technology, or things like avoiding tight pinch. Next, we would do hands-on practice. For example, simulating prepping a sandwich. Then we would do the client reflection. For example, what are things that you will remember for next time? Our interventions have multiple goals. For example, teaching joint protection, promote motor planning and activity modification. It also increases task efficiency and reduces strain on small joints, promotes functional independence through activities, supports client education and self-management, improves fatigue management, works on sequencing of various tasks, as well as addresses psychosocial aspects. Here are our references.